acetaminophen granules, and that's just do the dosing that you can see on the slide. You can also give an antifungal shampoo. You can use it, I usually say, once a week. Twice a week is probably too much for people of African descent. The hair is too dry. You can use topical antifungals, lotions, and creams, and consider a culture if it's recurrent. And then lastly, we'll talk about seborrheic dermatitis or dandruff. And again, a little more common in African Americans, and the question was, well, is this due to the frequency of hair washing? Again, typically hair is washed maybe once every 2 weeks. In the vast majority of patients, once every 2 weeks, that would be a typical pattern of hair washing, but really there's no association with frequency of hair washing with seborrheic dermatitis in the Detroit study. The risk factors are hair extensions, a history of chemical relaxers, and ironically, infrequent hair oil application. So the less frequently you put hair oil on your scalp, the more likely you are to get seborrheic dermatitis. So the key take home with sebderm or dandruff in your patients is ask about the vehicle. You might think, oh, a solution is best for the hair, but in most people of African descent, solutions are alcohol-based, would be too drying and contribute to breakage. So I asked the patient, would you prefer an ointment, a cream, a foam? There's some foams that don't have any alcohol in them. They're petroleum-based foams that are very effective in these patients. So do not automatically think hair solution. You want to think hair, and most of these patients are going to choose an ointment. Most of them will. But just it's important to ask. So how often do you wash the hair? In this study I mentioned, 61% of patients, the vast majority, shampooed every 2 weeks. 22% shampooed once every week or more often, and 17% shampooed every third or fourth week. So what you can tell your sebderm patients is once weekly washing. Don't give a shampoo and say use this every day, because they'll never do that, and it will actually make their hair very fragile and cause some breakage. So the take-home message is there's no correlation with the frequency of hair washing and seborrheic dermatitis. Once weekly hair washing is fine. So I just wanted to end with the natural hair movement. This is a new movement that's really all over the world, where women are stopping processing their hair and chemical relaxers and all of these things, and starting to just grow natural hair. And we'll see the impact on dermatology in the next 10 to 20 years. I think some of our hair disorders might go down. Traction alopecia might go up if we have a lot more tight, braiding and so forth. But it's just something to be aware of. A lot of your patients are going to say, oh, I have a natural hair now, or I'm going to go natural. That means they're going to stop all chemicals in the hair. So our take-home messages for traction alopecia: apply braids or extension to natural hair, not chemically relaxed hair. For tinea capitis and seborrheic dermatitis, there's no relation to the frequency of washing, so once weekly is more than enough. For CCCA, there's a strong association with braids and extensions, so I do avoid those in my patients. And there's no relation to relaxers or hot combs based on the studies. And very importantly, tell all of your patients who use glue to stop using it for the risk of anaphylaxis in latex allergic patients and the main risk of permanent alopecia. Thank you. So I know that was a lot of information. I don't know if you have any questions. Yes. It's great. So that's a great comment. So a lot of my patients will say, a very common question, what should I use on my hair? What type of products? I do recommend coconut oil, because moisturizing that very dry, brittle hair is very important to prevent breakage. Dry hair breaks. The more oils and emollients that are in the hair, the less likely it is to break. I like coconut oil because it's rich in antioxidants. The other one I suggest is olive oil. So those two, if your patient says, what kind of oil can I use, you can feel confident with those two recommendations. I think there was a question over here. Yes, sorry.
Yeah, I just wonder, well, what's a relaxer? Like, what does it do? Like, what does it have?
It's sodium hydroxide, which is essentially lye. And lye breaks the disulfide bond to straighten the hair. It permanently straightens the hair. And you might hear the term no lye relaxer, which is, or sometimes they'll say, I'm going to do a kiddie perm or a no lye relaxer. That's guanidine hydroxide. They both break the disulfide bonds to chemically straighten the hair. And the main difference is that guanidine hydroxide causes less skin irritation. So lye burns. It's like putting lye on your skin, it burns. For me, in some ways, that's not necessarily bad because it's not left on the hair too long because most people can't tolerate it. After a while, it's burning and it has to be washed off. With the no lye relaxers, even though they're more gentle on the skin, they're more likely to be left on longer because there's no burning sensation. So with no lye, I tend to see sometimes more drying and breakage because there's over-processing. Yes?
This is for Indian population, not African, but for Indian people, recurrent alopecia, how would you treat it?
The hair loss in the Indian population?
Recurrent alopecia.
Which alopecia?
Alopecia
Recurrent.
areata.
Oh, okay, alopecia areata. So at the university, we have a specialist in alopecia areata, Dr. Schachner, and so I use basically his regimen, which is we do for localized lesions, intralesional triamcinolone, usually 4 milligrams per cc, and the reason why he uses 4 milligrams per cc is because he thinks it's less likely to give atrophy. We do it once a month until it's resolved in a topical steroid, and then for people with more diffuse hair loss, the whole scalp, we do it in a headband pattern. So the first month they come in, and it's at this headband. The next month, 1 or 2 inches behind. The next month, 3, and you just kind of do it in a headband pattern going back, and then restart at the front when you've completed the whole scalp.
Is there any correlation with mold infection and getting alopecia?
Is there a relation with, oh, okay. So with alopecia areata, it's autoimmune, so I don't think there's a clear relationship with that. But with the CCCA that you see in people of African descent, there is possibly a correlation with a history of tinea capitis in the past. And the slide that I showed you of the parent who had tinea capitis, she was a carrier, that patient is still my patient, and 10 years later she did develop CCCA. So there is a correlation with the CCCA and tinea capitis in the past.
Is there any particular test you would do for that?
Well, CCCA you can biopsy, and typically you don't see fungus, but if I see scale on the scalp of an adult, I always biopsy and ask them to check a PAS just to make sure there's no fungus.
Thank you for such a nice presentation.
Thank you. Yes.
Yasmin, I'm a Toronto area family doctor. I see a lot of tinea capitis. It's a bit of a struggle for us to treat because the terbinafine isn't approved for children under 18.
Yes.
If you could maybe comment on some of the adverse events you've experienced and kind of the monitoring of that.
So that's a great question because I am in a referral-based center, so I see patients who have failed therapies. The main take-home with tinea capitis is the dosing of the griseofulvin. I'm a little bit old-fashioned. I still use griseofulvin.
It's back-ordered. You can't find it here.
Say that again?
It's back-ordered. You can't find it here at all.
Oh, you can't find it?
Yeah.
Oh. Well, anyway, so the dosing that's key, I have to say, is that most patients who have failed have been on 10 milligrams per kilogram, and you have to up it to 20 to 25 for the full 6 to 8 weeks. With the terbinafine, really, the FDA insert does recommend that you check LFTs, and sometimes we do that, but with all of these medications, these children are so young, I've never seen any adverse events with liver function, and I treat a lot of tinea capitis in Miami.
Okay, great. So then you do baseline and then like Q 2 weeks or?
No, so you would just, everybody's different. I would say at the university, some people do baseline, some people will repeat it at 6 weeks because they're on it for, 6 to 8 weeks. You really have to give that full 8 weeks. It's not a 4-week treatment to get rid of the tinea capitis.
Right, but the monitoring you just do kind of at the
You could do a baseline and maybe 4 to 6 weeks at that follow-up visit. And usually I bring them back at 4 to 6 weeks.
Okay. And then just a little quick follow-up. I met a Canadian dermatologist who said that sometimes she uses fluconazole for tinea capitis. Do you have experience with that?
I don't have experience with that. It was used in the past. I think, before many of these things, we used any antifungal. I remember I met one doctor who also used fluconazole. I don't have personal experience with that.
Okay, great. Thank you.
Last question.
Yes.
Harvey Shapiro, dermatologist in Toronto. Just in regard to the last question that just came up, griseofulvin, it's true, is not available in Canada, which for Americans is hard to believe.
Yeah.
But shearing and other companies have just stopped because I guess the market's not big enough. So it has become an issue, and there's a paper to be published, actually myself and Jonathan, my son, it's just except for publication. It'll be out in a few months in the Canadian journal, dermatology journal, on that issue. And because we did a study in our local area where we see a lot of dark skin, and it is an issue. And so Lamisil or terbinafine is our standard of therapy now in locally. And as far as monitoring, the general feeling now is that when we're using it just for the 4 weeks or so, as we use it for tinea capitis, tonsurans, monitoring probably is not necessary. Even I don't take any blood from my children before treatment. The only time I'll monitor with the use of terbinafine is in my fungal nail infections, where I'm putting patients on for 3 months.
Right.
So, and I do a pre, and sometimes I'll do 6 weeks into it as well, even though that's not in the product monograph. The other thing, you mentioned coconut oil, and it's interesting because coconut oil certainly is very helpful, but just recently I saw a patient who broke out in a rash, and she was positive to cocoamidobutane, which is on the standard North American 80 series of patch tests. And a lot of people don't realize that that is coconut oil. So basically, and she was positive to that, and she stopped using her coconut oil, and she was fine.
Thank you so much. This is why I love these meetings, because I learned something new today. Thank you.
Thank you very much, Dr. Woolery Lloyd, for enlightening us on the structural differences, cross-linkages of hair of African American descent, and the many nuances, considerations, even business opportunities associated with hair, and the many forms of alopecia, including CCCA, as well as the various scalp pathologies. I appreciated your terminology. Natural hair movement sort of makes me want to think that the United Nations will have also a corresponding declaration of human rights to, human right for full lovely hair. And I should also mention that her comments that refer to African Americans also, of course, apply to African Canadians, even if we spell the word color with one more letter. Our next presenter will be Dr. Yvette Miller Monthrope, who is an academic dermatologist at the University of Toronto at Women's College Hospital. She's the director of the undergraduate dermatology education, as well as the director of the Ethnic Skin Research Unit. She'll be presenting to us on the effects of sun damage, skin cancer considerations in persons of color, COLOUR, because it's spelled in Canada. Dr. Yvette Miller Monthrope.
So thank you very much for having me come speak with all of you today. I'm going to be talking about skin cancer, as Dr. Kadri mentioned, in persons of color. And it's a little bit of a switch from what we've been talking about so far, but it's something that's very important, I believe. So I have received honoraria for advisory boards from the following companies, none of which have anything to do with this talk. So basically, the way I'm going to present to you today, I'm going to give you a little bit of a background, and then I'd like to sort of do a case-based approach, and then we'll sort of conclude at the end. So we know that skin cancer is an extremely important public health issue, and it's the most common malignancy in Canada. According to the World Health Organization, 1 in 3 cancer diagnoses in the world are skin cancers. In the United States, skin cancer is more prevalent than cancer of the breast, lung, prostate, and colon combined. If we look at trends in Ontario and actually throughout Canada, the diagnoses of skin cancer actually mirror those that are in the US. So when you look here seeing that the prostate, colon cancer, breast, and lung cancer, I don't know how to do this out there, make up sort of almost half of cancer diagnoses here, you'll notice that skin cancer is missing. And that's because when you actually combine all of the numbers for those cancers, you get the numbers of skin cancer. So clearly it's a major public health issue. But I'll be talking to you about skin cancer in persons of color. So skin cancer incidence in people of color is much lower than that than those in Caucasians. This is mainly thought to be due to the protection from ultraviolet radiation by the type and distribution of melanin, which is found in darkly pigmented skin. So skin cancer represents up to 45% of all cancer diagnoses in the Caucasian population, but 2 to 4% of neoplasms in Asians, and about 1 to 2% of neoplasms in Blacks and Asian Indians. But despite the slower incidence of skin cancer in darkly pigmented individuals, morbidity and mortality rates are much higher in persons of color when compared to our Caucasian patients. And the reasons for this discrepancy include the advanced stage at the time of diagnosis and some biological and immunological factors, which we can talk about. I just want to sort of talk a little bit about some structural and functional differences in skin of color. So we know that all skin contains melanocytes, which are the pigment-producing cells. But the number of melanocytes is actually equal across all races. So skin color is actually dependent upon the amount, density, type, and distribution of the melanin within these melanosomes. And the difference within melanosomes, and the difference in melanome size, density, and aggregation is what determines skin color. So basically, the melanosomes and the melanin are basically what cause patients to be more protected, people of color, for example. So people who have black skin, therefore, have a natural SPF of about 13.1, and patients who are Caucasian have a natural SPF of about 3.4. So as you can see, even an SPF of 13.1, we tell all of our patients that they need to use SPF of at least 30 or higher. So people of color are not completely immune with this natural SPF of 13.1. So just after that background, I'd like to go through a couple of cases, and I'd just like to see your perspectives on some of these. So the first case I'd like to present is one of a 72-year-old woman originally from Colombia who presents with a 2.5 centimeter non-healing brownish black nodule on the jawline. She reports some tenderness and occasional bleeding. So here's the case. So as you can see, a large nodule and brownish black and discoloration, ulceration in the center. So I kind of like to see a show of hands here. So in terms of the diagnosis, what do you think is the most likely cause here? Is this a melanoma? Is it a basal cell carcinoma? Okay, a few people there. A seborrheic keratosis? Pigmented actinic keratosis? A thrombosed hemangioma. So we know it's not that one. But, so this is actually a basal cell carcinoma. Basal cell carcinomas are the most common skin cancers in Caucasian, Hispanic, and Asian patients, and the second most common skin cancer in Blacks. They're typically found in sun-exposed sites, such as the head and neck area. And BCCs represent 65 to 75% of skin cancers in Caucasian patients, 20 to 30% of skin cancers in Asian Indians, and 2 to 8% of skin cancers in African Blacks. What's unique about basal cell carcinomas in people of color is that they tend to be pigmented in more than 50%. So it wouldn't have been wrong to think in that picture that I showed you that this could have been a melanoma because of the marked amount of pigmentation. But oftentimes, if you're going to see someone of color who has a basal cell, it will often be pigmented. Only 6% of basal cell carcinomas are pigmented in Caucasian patients. Another thing that's important to note is that if you ever see a black patient, someone of type 6 skin who presents with a basal cell carcinoma, these patients have a higher incidence of a second non-cutaneous tumors. That tells us that maybe there's something more going on than just sun or UV radiation, maybe something genetic or immunologic, which has made them develop a basal cell carcinoma and other tumors. So if you see a black patient with a basal cell carcinoma, it's probably a good idea to send them for at least at minimum a chest x-ray. So ultraviolet radiation is the primary risk factor for the development of basal cell carcinomas in all skin types, but other risk factors include radiation, exposure to arsenic, immunosuppression, scars, ulcers, injuries, thermal injuries, and genetic conditions. prevention is really about modifying these risk factors, including sun protection and early detection. The treatment can include, if it's a superficial basal cell carcinoma, certainly not the one I showed you, you could use cryosurgery. As Dr. Alexis kind of mentioned or alluded to earlier, cryosurgery in patients of color can lead to significant scarring. And the reason for that is because liquid nitrogen has negative 197 degrees Celsius temperature, and a melanocyte will die at -4 to -7 degrees Celsius. So that's why you get that major dyspigmentation. So I'd be cautious using cryosurgery. Electrodesiccation and curettage can be used, excision, and Mohs micrographic surgery. So the clinical pearls I'd like to leave with you for basal cell carcinomas in people of color is that they are often pigmented, and for darker skinned individuals presenting with a basal cell carcinoma, you can consider screening for other primary cancers. This is just an example of another pigmented basal cell carcinoma. We see that rolled border and the pigmentation. This is one of my Caucasian patients, but it's the same idea. And here's another one also. You see that rolled border and the pigmentation as well. So the second case is of a 28-year-old East Indian woman presenting with a new growth on the lower lip. This is an area previously affected by discoid lupus erythematosus. So when you see this young woman, you see that she has marked dyspigmentation throughout her entire face. That had previously been biopsied showing discoid lupus erythematosus. But this is really what we're looking at right here, this tumor just on her lower lip area. So what do we think the most likely diagnosis is in this case? Do we think it's a basal cell carcinoma? Anyone? A squamous cell carcinoma? A wart, seborrheic keratosis. Could it be hypertrophic lupus erythematosus? It's possible, sure. Okay, so this is an example of a squamous cell carcinoma. It's the most common malignancy in Blacks and East Indian patients, up to 65% of all skin cancers. The second most common cutaneous malignancy in Caucasians, Chinese, Asians, and Japanese. So SCCs occur most commonly in sun-exposed sites in Caucasian patients. However, in skin of color, SCCs are much more likely to occur in skin-protected sites, such as the scalp, the lower legs, the anogenital region. So the bottom line here is that ultraviolet radiation is not at all a primary risk factor for squamous cell carcinoma in the development in non-Caucasian populations. The most important risk factor in Black patients to develop an SCC is a chronic scarring process or chronic inflammation. In a review of 524 cases of squamous cell carcinomas in Nigerian Black patients, the most common predisposing factor was actually a chronic leg ulcer. Especially many of you here today who are practicing family physicians, I'm sure you see many leg ulcers, and if you see these and they're not healing, in patients of color particularly, you might want to consider doing a skin biopsy to rule out a squamous cell carcinoma. Other risk factors include immunosuppression, genetic conditions such as albinism, and HPV virus infection. The prognosis of squamous cell carcinomas in people of color is not great, actually. So people of color tend to have more metastatic squamous cell carcinomas. And the reasons for this often include a delay in the diagnosis and inherently more aggressive tumors, which has been thought to be related to immune function. And tumors that tend to arise in these areas of chronic inflammation have a 20 to 40% increased risk of metastases versus 1 to 4% risk of metastases in sun-induced SCCs that we most commonly see in Caucasian patients. So the treatment is really to try to prevent or treat these inflammatory conditions and to detect these tumors early. The treatments include excision, electrosurgery, and Mohs surgery. So the pearls for this case include squamous cell carcinomas are more aggressive in people of color, and that ultraviolet radiation is rarely associated with the development of an SCC. Here are just some other examples of squamous cell carcinomas. This is actually a squamous cell carcinoma that developed in an area